Diagnosis of urinary tract infection in an infant. Infant can present with jaundice, sepsis, failure to dry, vomiting, fever, urinalysis, prepubic perspiration for urine culture, CT with or without IV contrast, ultrasound of kidneys and bladder for abnormalities, voiding, cystoretrogram, vascular reflex if under 2 months, perform urinalysis in any year appearing or febrile infant, and from 2 to 24 months perform urinalysis if fever over 39 lasting 48 hours for no other apparent cause. Urinalysis in an infant will most likely have to do transurethral catheterization or suprapubic aspiration can try to clean cat urine sample, but this will not be suitable for culture. Only once keep toilet trained. The negative urinalysis result usually rules out UTI. If positive culture, if urinalysis positive or negative but high clinical suspicion, also do urine culture. Imaging study required for any child under 24 months and renal ultrasound for structural abnormalities. If present other voiding cystoretrogram VCUG, if all R3 tests are negative, they may obviate the need for culture except in neonates and where urinalysis results are less reliable predictors of infection. Ultrasonography of the bladder and kidneys is recommended for infant and non-toilet trained children with first-time febrile UTI to exclude structural abnormalities or detect high withdrawal necrosis. Diagnosing a urinary tract infection UTI in an infant involves a combination of clinical assessment, laboratory tests, and sometimes imaging studies. The approach is meticulous due to non-specific nature of symptoms in this age group and potential for significant morbidity if the infection is not promptly treated. Clinical presentation symptoms in infants can be non-specific and include fever, irritability, lethargy, poor feeding, vomiting, diarrhea, jaundice, and failure to drive. In some cases, there might be a change in urine odor or color. Physical examination might reveal fever, probably tenderness, or flank pain, although these findings can be subtle or absent in infants. Laboratory test urine collection. The method of urine collection is crucial for accurate diagnosis. Option includes proper aspiration, gold standard, but invasive catheterized specimen less invasive but accuracy or cooling catch difficult to obtain. Uncontaminated sample in infant urinalysis leukocyte to esterase indicating presence of leukocytes, white blood cells in the urine suggesting inflammation. Nitrites indicative of bacteriuria, as many bacteria can convert nitrates to nitrite. Microscopy finding of diarrhea, 5 white blood cells per high power field is suggestive of UTI. Urine culture considered the gold standard for diagnosing UTI. It helps in identifying the causative organism and determining its antibiotics. Biotic sensitivity of positive culture is typically defined as over 50,000 colony-forming units per milliliter. A single uropathogen is a specimen obtained by catheterization or suprapubic aspiration imaging studies. Ultrasound of kidney and bladder recommended by some guidelines after the first febrile UTI in infants to evaluate for anatomical abnormalities through the timing and necessity debate. Voiding cystoretrogram VCUG may be considered after a first or recurrent UTI to assess for vascular reflex VUR. However, its use is controversial and often reserved for specific cause due to the invasive nature and exposure to radiation. Differential diagnosis is important to consider and rule other causes of fever and irritability in infants such as viral infection, meningitis, gastroenteritis, or sepsis, especially given the non-specific presentation of UTI in this age group. Management implication. Early diagnosis and appropriate antibiotic therapy are crucial to prevent renal scarring and other complications. The choice of empirical antibiotic is guided by local resistance pattern and should be adjusted based on culture and sensitivity results. Infants with UTI may require close monitoring and some may need hospitalization, especially if they are febrile, less than 2 months old, unable to retain oral intake. High yield points for medical examination. Remember the non-specific presentation of UTI in infants and the importance of considering UTI in the differential diagnosis of fever without resource and understanding the significance of urine collection method in diagnosing UTI in infants. Recognizing the urine culture as a gold standard for diagnosis and the role of imaging in evaluation of febrile UTI. And diagnosing UTI in infants require high indexes suspicion and prompt evaluation due to the potential for rapid progression and significant morbidity associated with delayed treatment. So let's know what you have read today. Diagnosis of urinary tract infection in infants. Infant can present with jaundice, sepsis, failure to dry, vomiting, or fever with analysis. So proper aspiration for a urine culture, CT with or without IV contrast, ultrasound of kidney and bladder for abnormalities, voiding cystourethrogram. For vascular reflux, if under 2 months, perform urinalysis in our ill appearing or febrile infant. From 2 to 24 months, perform urinalysis if fever over 39 degrees, I think over 48 hours. No other apparent cause urinalysis in an infant most likely have to do transurethral catheterization or suprapubic aspiration can try point catch urine sample. Negative urinalysis result in visually rural UTI and if urinalysis positive also do the urine culture, imaging study required for any child under 24 months. If all tests are negative, may alleviate the need for culture except neonate, where urinalysis results are less reliable predictor of infection. Ultrasonography of the bladder and kidneys is recommended for infant and non-toilet trained children with first-time febrile UTI to exclude structural abnormalities or detect hydronephrosis. Diagnosing UTI symptoms infant non-specific include fever, irritability, lethargy, poor feeding, vomiting, diarrhea, jaundice, failure to drive. Physical examination might reveal fever, probably tenderness, flank pain. Laboratory test, urine collection is crucial for accurate diagnosis. Clinical presentation, symptoms, specific examination, urine collection, aspiration, gold standard, but invasive catheterized specimen, less invasive, good accuracy, or a clean test difficult to obtain uncontaminated sample in infants. Urinalysis, leukocyte esterase, indicating a presence of leukocytes, white blood cell in urine, suggesting inflammation, nitrates, and microscopic finding of pruriria over 5 white blood cell per high yield, high power field is suggestive of UTI. Urine culture considered the gold standard for diagnosing UTI, have identifying causative organism, determining its antibiotic sensitivity. A post culture is typically defined as over 50,000 colonies forming units per milliliter of single pathogen in specimen or imaging studies ultrasound of kidney and bladder recommended by some guidelines after first febrile UTI in infants evaluate for anatomical abnormalities, though the timing and necessity are debated. Avoiding cystourethrogram for CUG considered as a first or recurrent UTI. Differential diagnosis, fever and irritability infant such as viral infection, meningitis, gastroenteritis, sepsis, especially given the non-specific presentation UTI in this age. Group management, invocation, early diagnosis, and appropriate antibiotic therapy crucial to prevent screening, high yield point remember non-specific presentation of UTI in infant and importance of considering UTI in differential diagnosis of fever without sources. Understand the significance of urine collection method in diagnosing UTI in infants. Recognizing urine culture as a gold standard of diagnosis and the role of imaging in the evaluation of febrile UTI.